Assalamu alaikum everybody. This is Dr. Mawada and today we've got a new clinical case in the cardiology block. So let's get started. We've got a 60-year-old man. He's complaining of a progressive shortness of breath, dyspnea, unproductive cough. Okay, let's read more. He was told to increase his diuretic, but this did not help. This can be a sign for something I'll tell you later. But we normally give the diuretics in patient with cardiac failure. Keep this in mind. Okay. In the past 5 years, he had a myocardial infarction with left ventricular systolic dysfunction. He was treated by an implantable defibrillator and his ejection fraction is 20%. So let's see what happened next. 6 months ago, he had a tachycardia and he was treated by antiarrhythmic drugs. Let's see his vitals. His blood pressure is normal, pulse as well. His mucous membrane is moist. The examiner is giving you this hint in order to direct you to choose or eliminate an answer later. So the patient is not dehydrated. Let's continue. He has no jugular distension. This is also a hint. The jugular vein is usually bulged when there is a cardiac failure or heart failure. So the fluids or the preload is going back into the inferior vena cava, leading to jugular distension. Here there is no cardiac failure. So this is also a hint. There is an inspiratory crackle. There is no cardiac murmur. This is also maybe leading us. And no peripheral edema. Okay, so the X-ray is showing a bilateral infiltration in the middle of the lungs. The main question is, what is the main cause of this dyspnea? Let's say the choices. We've got an advanced heart failure. We've got an antiarrhythmic toxicity, diuretic toxicity, tricuspid valve, viral pneumonia. Always remember in solving clinical cases to use the hints that are mentioned and what diseases the patient has gone through and how they were treated. Sometimes the time period that the patient was treated in is also essential. So I'll try here to eliminate the wrong answers by reading the question. So let's see, what about C? Is this dyspnea caused by diuretic toxicity? The question mentioned that the mucous membrane of the patient was moist. This means that he's not dehydrated. He has no electrolyte imbalance. And even though he was treated with an overdose of the diuretic, this did not cause him toxicity. So C is wrong. So let's see A if it's correct. Sometimes progressive dyspnea is a sign of cardiac failure, but let's check the other signs. Cardiac failure usually presents with distended jugular vein, and the accumulation of blood in the system leads to hepatomegaly and peripheral edema. Here the question says that there is no jugular vein distension or peripheral edema. Heart failure would normally respond to diuretics, but here in the question, an overdose of the furosemide did not prove in the case. So A is wrong. Now let's see if the tricuspid valve is causing this dyspnea. Usually problems with tricuspid valve would normally cause a holocystic murmur and right-sided heart failure. The question mentioned that there is no cardiac murmur and there is no peripheral edema. So D is also false. So we've got two options now left. We've got E and B. So let's decide if this is a viral pneumonia. So viral pneumonia do cause dyspnea and cough, but it comes with fever. And here is the patient is not suffering from fever. And the time course of symptoms after starting the antiarrhythmic drug and the other investigations are leading us to interstitial pneumonia caused by the amiodarone, which is an antiarrhythmic drug. So E is false and B is correct. This is an amiodarone-induced pneumonitis. Amiodarone is a potassium channel blocker. It's used as antiarrhythmic drug from the third class. It's often used in the ventricular arrhythmias in patients with CAD or ischemic cardiomyopathy. Here are some side effects of amiodarone. It affects on the heart, lung, thyroid, liver, and skin. Here is an interesting picture to remember the side effects of the amiodarone. So the A represents amiodarone, and it's blue because it causes a blue skin discoloration. There is a thyroid, there is a hypothyroidism and hyperthyroidism. There is a lung fibrosis, liver fibrosis. There is also a sign of a heart, which represents the cardiac side effect, like sinus bradycardia, which is another type of arrhythmias. Torsade de Pointes, which is a type of QT interval prolongation. And here is the torch representing photosensitivity, which is an optic neuropathy, which means it's an ocular side effect of the amiodarone. Back into our question. So the amiodarone has a chronic pneumonitis effect on the lung. The patient presents with progressive dyspnea, non-productive cough, bilateral crackles, and here is what we see on X-ray. It's a glass ground opacity.